Hey, good morning. I think I remember to turn this on. I'm Kristin. I think one of the reasons, like one of the top 5 reasons when you ask people why they go into psychiatry is that they don't want to round at 7 a.m. So I'm just going to put that disclaimer out there. You can do what you want. So thank you for kind words, Dr. Hrinovich. We want to round together so we can have our patients practice our last names on a regular basis. Kasia and Kristin. Dr. Hrinovich and I have been working for a while together, and she has, I'm gonna kind of come clean here. This is her topic. She regularly says this, does the mind matter? And my regular response is, whose mind? Are we talking about the patients, the providers, or the, I don't know who else would be involved, but we've had these long conversations about like, how do we talk about mental health in medical units? And I'm gonna try to do that a little bit today. So the other thing is that I could stand here and ramble, and I do that quite often, stand and ramble. But I would really appreciate if you have questions during, that would be like great. It kind of helps me also figure out like, what are the things that you want to know? What are the things that you already know, and all that stuff. So no affiliations to disclose. So this is some of the stuff that we're going to talk about today. I'm going to talk a little bit about the CONSULT-LIAISON service here at Abbott, cardiovascular illnesses and mental health, and then assessment and treatment of depression. And you probably all know why I picked that one. So I never talk anywhere without bragging about the awesome team that I'm part of. I don't know, many of you might have worked in a lot of systems where you have services like this, but I haven't. I've worked in a number of different healthcare systems here and back in Iceland. We did not have this service where you had a team of providers in the medical hospital seeing patients on a daily basis as needed, as was called for by our colleagues. So I work here at Abbott Northwestern. I've been here since 2015. When I was hired, I was the 3rd hire to a team of psychiatric mental health providers, and we've stayed a team of 3. So we're 4 people, but on most days, it's like Monday through Friday, we are 2 psychiatrists and an NP. And that's a big team. And this is a huge shift in service, I think, from where we completely like, this is the psychiatric world and this is the medical world. And, and we call each other like barely. So I just feel so privileged of being a part of that. So we covered the whole hospital. We see the med-surg patients. We go up to cardiology a lot, neurology, the ICUs, the mother-baby center, and down in Kurtz County. And what has happened in those 4 years since I've been here, 4.5 years, is that like they know we're there. Like, so it's increased, the calls are increasing in terms of like, hey, can I just run this by you? And that's kind of, for me, it's truly the essence of collaborative care. So on the right side, you can see who we see. So the largest portion of our consults are for depression and anxiety. We also see patients for delirium, dementia with behavioral disturbances, dual diagnosis patients, so patients with substance abuse or substance use disorders and mental health issues. We see, and this is again unique to our role, conversion disorder, somatic symptoms disorder. Do you guys know what that is? So conversion disorders are neurological symptoms not explained by a neurological disease. So it's your old words were like pseudo seizures. We now call them non-epileptic events. We see a variety of those, paralysis, syncope, dizziness, headaches. And then the somatic symptoms disorder, this is where it gets really fuzzy, is the people who actually have medical diagnosis that could explain some of the symptoms, but not all of them. A lot of this is, for instance, chronic abdominal pain. We see a lot of people with these somatic symptoms come to the hospital repeatedly, have a really extensive, thorough workups done more than once, more than twice, and then they call psychiatry. It's like, what do we do next? Capacity, we all can do capacity. That's my motto. So when they call and say, can you do capacity? I said, yes, so can you. So capacity, we are often called in very complicated situations where we have to kind of put in our input on if patients can make their own medical decisions or not. Mental illness, so this is other mental illnesses is what my colleagues anywhere else are mostly treating. It's your patients with bipolar and schizophrenia, but we see very few of them. And then for medication management, for instance, clozapine is, they put in a hospital-wide policy that you need to call psychiatry for all clozapine patients. So this is kind of the framework we work within, right? So we talk about the psychiatric illnesses as risk factors for medical problems, and that's going to be kind of what we're going to talk about today, but also it's this, it's the, in the purest sense, because there's no kind of, for me, there's very, very fuzzy outlines of this. In the purest sense, this would be your anorexic patient in with malnutrition. Like that's the kind of probably the purest, like there's a completely, the psychiatric illness is causing the symptoms while they're in the hospital. Psychiatric treatment is a risk factor. We often are called because of side effects of different medications. The medical illnesses causing psychiatric problems. This is our delirium patients. This is thyroid problems. We kind of put dementias down there too. Psychosomatic issues that I talked about earlier. And also this, we do a lot of this too, see patients who are struggling in the hospital. And they don't necessarily meet the criteria for a mental health diagnosis, like for psychiatric diagnosis, but this is like one of the premise. Mental health is not only the absence of a diagnosable illness. So, and I know that you guys work in that paradigm too. So I always put this one up. Just for us to kind of like think about how complicated it is to be a human, but also to kind of think about why you would wanna have in mind things like mental health, psychiatric illnesses when you are treating a person. So from kind of the left side, genetic vulnerability, childhood adversity, we are seeing an increase in research showing the adverse effect of what we call ACE, no, what is it called? Say it again. Childhood adversity. Childhood adversity. There's an acronym for this that I can never remember. So they have like a really long checklist that they have been working on, and the outcomes are that adverse childhood adversities, here we go, can impact our mental health and our psychiatric and our physical health later in life, and that they are cumulative. So more of those, the bigger the impact. That alone can cause what we call this maladaptive attachment. This is how we relate to the world and to one another. Also can cause depressive and anxiety disorder, also feeds into this behavioral risk for chronic diseases. So you're more likely to not live a healthy lifestyle, obesity, smoking, and that also that feeds into, so if you go back to the adverse childhood events, put in this kind of life after that, then you have this chronic stress state that increases your, sorry, now my brain is freezing. So it basically, it kind of throws off your immune system, your endocrine system, and this chronic stress state can cause the pro-inflammatory factors to increase. All of this then increases the risk of getting a chronic medical disorder. We have diagnosed, and we have linked these things to both diabetes, cardiovascular diseases, and more. And then when you have a chronic illness that you have to manage, that also then feeds into the whole loop again. So it's a lot of places where we kind of like come in and look at like how is mental health affecting overall clinical burden of a chronic illness. So what mind? We kind of like go everywhere. So this includes our, when I think about like mind and medical problems, it's not just the psychiatric illnesses, it's also just like our cognition, our mood and affect, personalities, and then I like to talk about the X factor. This is something that everyone in psychiatry knows. It's what makes our life more difficult and more complicated. Is that it's the human part. It's the factor that makes us human, where the sum of the things that are going on in our minds are greater than the individual parts. It's the people who come to your clinic and you're like, this is gonna go horrible. And then it's, it goes really well. And it's the people who have like it's the magic kind of about being human, where you have resilience from being with other humans, where you have kind of like these unquantifiable and often undefined things going on at the same time. We can't treat those. We barely can measure those. We always try. But that's one of the things that makes, mental health care and psychiatric illness is often very complicated to define and to kind of put in a nice tight box where we kind of have everything under our control, which would be nice, right? If I could just have everything under my control. Unexpected issues in psychiatry. People are human. So most of this, we're going to talk about psychiatric issues in cardiology. Again, please ask me questions. If you have any input, patient questions, anything. So it is estimated that patients with severe mental illness lose about 24 or more of their life, and majority of those are losing it because of cardiovascular disease, not suicide. So I think they say estimated numbers like 60% of early deaths in mental health are because of cardiovascular diseases. So the risk factor, so that when I say severe mental illness, I'm referring to the severe persistent mental illness that we treat: bipolar, schizophrenia, and major depressive disorder. So the risk factors include they're much more likely to smoke than the general population, like way higher prevalence. There's like a whole body of research on why that is and how hard it is to help them not smoke. There's considered like a 1.5 to 2 times higher prevalence of diabetes, dyslipidemia, hypertension, obesity. People with severe and persistent mental illness are likely to be on medications that have so all our antipsychotics have a profile of causing or resulting in metabolic syndrome. However, there are research out there that are showing that it's not the metabolic side effects are maybe kind of the lowest percentage of this problem. The other problem is they increase appetite, period. So people are now just eating more. They're more hungry, they're eating more. So that is kind of what they're showing is like, that's a bigger problem. So maybe we can help people who need to be on these medications, and this is on psychiatry, to have some help with that piece. The other side of this, and this is where we all come together, patients with severe mental illness who have like an MI or an adverse cardiac event, they're less likely to receive standard treatment. So when they come into a hospital, they are less likely to receive medications that we know are helpful, including ACE inhibitors, thrombolytics, aspirin, stuff like that. They're less likely to undergo a heart cath, although like I'm not completely sure of why. So we have, and maybe this is why I'm so excited about the service here at Abbott, but there's a long, long, long history of healthcare disparities for people with mental illness. They do not get medical care that people without psychiatric illnesses get. And that's just, it's very well researched. So this is very important to kind of note. So then there's all the research on the chronic stress, right? This has been the focus of cardiovascular research for a long time as well. And it's still feels like they're still searching for that common factor. What is it? Likely it's like multiple pathways that link the two together. Increased levels of, here's my accent tripping me up. In Icelandic it would be catecholamine. Okay, thank you. May affect the heart directly, platelet functions. And there's also like, is stress, the conversation is still going on in terms of like, is stress maybe the common denominator for cardiovascular diseases and depression, where there's this strong link between, right? There are ongoing studies on the changes in the immune system, including the higher circulating levels of like inflammatory factors. So if you think about state of panic, so your fight and flight response, your sympathetic nervous system is on, right? And this autonomic regulation is there to protect you from harm. And in a world of chronic stress, this shift, like there's actually considered to become like a permanent change in the regulation of that system. So perfect group of people to test it on are PTSD patients who have an increased basal heart rate, increased blood pressure, and have higher rates of cardiovascular diseases as well. So that's where a lot of the research has been going. And that this is like, that's like high level stress on a daily basis. That's the symptoms of PTSD, untreated PTSD. So you're on high alert always. Now they've also looked at people who have work stress to that level. And I don't know, how many people have come here to talk to you about burnout. But that's one of the things that they're researching, is that the same, like that then feeds into depression or medical problems, or both, probably both. Also worth mentioning, eating disorders. So both anorexia and bulimia, of course, malnutrition, prolonged QT, arrhythmias, cardiac atrophy, low cardiac output, vascular resistance increases, and then refeeding syndrome that we all need to be aware of. Substance use disorder, chronic alcohol use affects cardiovascular health. Methamphetamine or stimulant use. We see a lot of those patients come to the heart failure team. And then I always like to put in your specialty, white coat syndrome. I kind of feel like I have that now. Just standing here. New research on white coat hypertension, this phenomena when you come to the doctor's office, your blood pressure is higher than at home, actually is showing there is possibly a higher, there's increased, people who have that actually have increased risk of having hypertension, cardiovascular disease. I want to say metabolic stuff going on later down the road. So we're not, they're like, this was so long, just considered like, you know, like, yeah, you're scared of your doctor, and that's why your blood pressure is higher. So now we know a little bit more, and it might not be as simple as that. And because I'm a dramatic broken heart syndrome, this is your stress-induced cardiomyopathy. Research on that started back in the 90s, where postmenopausal women were having MI symptoms without having any obstruction. Again, it relates to the stress hypothesis, but it's not that simple. They also have found that maybe estrogen is playing a part there too. So research have continued on that. I read, so stress is such a vague word in our world today. We have like a list of stressors, like the highest perceived stressor in your life is to lose your spouse. And then they kind of rank it down. I think wedding is number 5 or something. So they also found that like there's like a small percentage of people who have had stress-induced cardiomyopathy actually have had it because of good things happen. So just want to tell you, like remind you of this when you have a surprise birthday party for your, you know, for your colleagues, like a retirement party that, you know, could end badly. So in that stress conversation, at the hospital is just like, I mean, this is completely like where I work, like where I'm like, are you sleeping? And no one sleeps in the hospital. Like one of the things that we need to do when we're stressed out is to sleep. It's where our brain actually cleans up the highways that we have created during the day. We have to sleep. And then you're in the hospital under a very stressful situation. Things are going, you know, there are a lot of things going on, and we can't sleep there. And it's like, you know, and I ask the question always, part of my assessment, are you sleeping? And you know, and I get the no, the nurses come in and poke me and prod me, or no, I'm on diuretics and I have to go to the bathroom every hour. And I'm just like, sorry about that. Okay, psychiatric treatment is a risk factor. I always want to talk about this because I am hoping that you are seeing someone in your clinic or in your practice, patients that have mental illnesses, and so you can be aware of this. So the antipsychotic medications we talked about a little bit, they're all noted to cause increased appetite, increased prevalence of metabolic syndrome. Lithium is a wonder medication. We have used it for a long, long time. This is the medication that has been described as a life-saving, life-changing medication, an agent that actually has helped people survive a debilitating state of bipolar. So we keep giving it, and nephrology keeps taking them off. So long term, it's like sky high, the prevalence of kidney failure on lithium. Most of my patients have to come off lithium. And they're like late 50s, early 60s, that life-saving agent. And they have to come off it because their kidneys are failing. Lithium toxicity can cause and result in a cardiac arrest. Tricyclic medications. Now, little reminder, before Prozac, before the early 80s, these were our go-to medications for depression. These are the medications that were most prescribed for depression. This is your amitriptyline, nortriptyline, imipramine. So if you have older patients or clients, then you might see them on these medications still. We work a lot of like, why stop something that works? So people get stuck on these medications for a long time. They were always a trouble. They're fatal in overdoses. So when we were using them to treat depression, that's one of the things that we had to be aware of. Like, are we giving a suicidal patient means to end their life? They can cause complete heart block, most commonly orthostatic hypotension. They're anticholinergic. People just feel dry. They can cause arrhythmias. And then also, so if you see someone on these medications or having cardiovascular issues, one of the key, when you're treating anyone of, how do I say this? Don't just take them off. Don't just take them off. Have the conversation. Like, you have this issue, this medication is probably contributing. Let's talk about alternatives and how you talk to your psychiatrist about the issue. Because going off this medication, again, they have been, many cases, life-saving. And destabilizing people like later in life is just, it's really hard. It's really, really hard. So the thing is too, like lived in a world where psychiatry and medical was very siloed. These patients also lived in a world where medical and psychiatric are siloed. So many of them don't realize they have to talk about their medical issues with their psychiatrists. And, and don't bring up new changes, new diagnoses. So, and then the last class of medication I want to mention is the stimulants that we use to treat ADHD and as a treatment to treat depression. They, of course, are prone to causing hypertension, tachycardia, stuff like that. Yeah. Yeah.
I think you bring up a really good point that when people are in the hospital and they're taking medication away, or heart failure or bleeding risk or whatever, the challenge becomes then when they leave the hospital and communicating with whoever is managing those and working. It's really hard to work collaboratively with psychiatrists and psychologists in the outpatient setting.
I know.
I find that to be
the
hugest challenge. So do you have any feedback or advice about that?
No, so yes.
Great.
That sounded really bad. Yeah, I do, but still. So no, I agree with you. And we often joke about it in the office. It's they called me back joke. It's better. It is better because we are now able to reach their, so how we do it is that we call their clinics and we leave a message with their nurses, right? Saying, your patient was in the hospital, we did medication changes, please see them in your clinic as soon as possible. Their discharge date is this. We try to do that for many of the patients we see. No, I know this is a challenge. This is, you know, we also have, like, again, there is a mild disparity that we're still working on, and mild is, I'm being polite. Like, for instance, we ask we work in this team, we're like, okay, we're planning for this patient to leave. We've messed up all their medications. We want to make sure that they have an appointment with their psychiatrist. And somewhere in our system, it has been decided that mental health patients need to make their own appointments. You know, and I don't know why this is, and I keep working on it, right? So there is still a communication issue between psychiatric providers and medical providers. Definitely. It's hard to get a hold of them. So, and they usually, and most of them are not in a system like ours. Like, they don't have EPIC. You know, that's like their clinics that work on their own, in their own kind of little silo. So it is an extra effort. I agree. Sorry, I didn't answer your question. This answer is still no, like I can't fix it. I know it, I can't fix it, right? So this all you should know, right? You have had, and this has been like probably one of my like joys to hear and see and assist with, is this extended work on disseminating, pushing forward, and supporting providers in recognizing and treating depression alongside cardiovascular diseases. Roxanne in the clinic, and Dr. Bradley in the hospital, both of them, like, and more people in this group have been like relentlessly trying to work on like, how can we improve this? And the thing is that it's because it has such a strong evidence, right? It's been studied a long time. So considered 1 out of 5 patients with cardiovascular diseases have depression. Much higher than, I want to say, the 12-month prevalence, like 7 to 9% in the community. These patients do worse. Now remember my first big diagram of how everything intersects. They do worse. They do worse in terms of managing their illness, and they have higher mortality rates. So I think it was, and there are people in here who know this much better than me, I think it was 2008, where the American Heart Association put out the advisory to, like, we should all be screening. We should all be looking for these patients, referring them to appropriate providers, or starting treatment for depression. So, so we've known this for a long time. Everyone is trying to increase the practice of this. And then the studies of collaborative programs that are addressing both things, medications being used more systematically in the cardiac practice and all that. Is it helping? And it's kind of still inconclusive. Some say yes. So one of the things that people are getting less depressed. That's, you know, in my world, that's a good thing. But the cardiac outcomes that are poorer with depression are not necessarily getting better right now. Like we don't see that improve as much. So this complicated mechanism, and again, like, there are people in here who can who can better than me describe to you the underlying pathways. There's so multiple systems that have been looked at in terms of this, and one of this is the stress model. The other thing is the no, I'm blanking again. Well, I'll come back to it later. So this is what kind of like has been most discussed aside from stress, in the cardiovascular literature in terms of mental health. So what's depression? DSM-5 is what we use in psychiatry to quantify, to group together cluster of symptoms to form a diagnosis. That's the most comprehensive I can explain it. We don't have any measurements. We don't have any lab tests. We don't have anything. So we take all these symptoms that we are hearing, so self-reported symptoms, and observing, clustering them together and come up with a diagnosis. We've been criticized for that. That's fine. So this is the DSM-5 diagnosis criteria for major depression. 5 or more for the following symptoms, and you have to have either one or two. So either the depressed mood or the diminished interest or pleasure or anhedonia. And then, so you have to have either of those to meet the criteria. And then it's the significant weight loss or gain with the increased or decreased appetite, insomnia or hypersomnia, psychomotor agitation or slowing, fatigue or loss of energy, feelings of worthlessness or excessive guilt. There was a spelling error there, sorry. Diminished ability to think, I'm sorry, again, or concentrate, indecisiveness, and then recurrent thoughts of death, recurrent suicidal ideation with or without a plan. So it's a lot of symptoms, and I kind of, 5 or more. Some of these symptoms you can see actually in heart failure, right? The diminished energy, lack of appetite. We kind of group them together, mild, moderate symptoms, if you just meet the criteria, but it doesn't have massive functional impairment. And the severe symptoms, all of them, and a lot of functional impairment and or psychosis. So when we're diagnosing it, think about these things. Mood disorder due to another medical condition. So medical conditions that can cause the depression include stroke, Huntington's, Parkinson's, TBI, Cushing's disease, and hypothyroidism. And then the adjustment disorder with depressed mood. So again, we're looking at cluster of symptoms and prevalence, like, so major depressive disorder, you have to have these symptoms for at least 2 weeks, most of the days or most days. Adjustment disorder with depressed mood doesn't meet that criteria. So it's more a response to a stressor. Substance or medication-induced depressive mood disorder, mixed episode of bipolar disorder or bipolar disorder. Sadness, grief, postpartum depression, dysthymia, which is persistent low mood for more time than not in 2 years. So there are a lot of like different diagnosis, differential diagnosis that has to be considered, because that also guides how we treat it, right? PHQ-9, everyone know what that is? Okay, so this is what we use in most primary care clinics and some hospitals settings. And there's a project going on right now on the cardiovascular units of using PHQ-9 to actually screen for patients. So this is just a description of how you do that. Lifetime prevalence in the general population of depression is over 20%. It is high. 12-month prevalence, 7 to 10. And then patients with chronic illnesses have found to have 2 to 3-fold higher rates of major depressive disorder, not only cardiovascular diseases, but also COPD, diabetes, MS, Alzheimer's, and stroke. Dermatitis, like, you know, like, again, pronunciation, tinnitus, yep, all have like really high prevalences of major depressive disorder. So this is what we talked about earlier: increased medical symptom burden, increased functional impairment, higher medical cost, poor adherence to recommended treatment, and then increased risk of morbidity and mortality. So I'm going to just fast go over some of the treatment options. So the thing is, most people being treated for depression are being treated in primary care, not in psychiatry. So this is, because I know that many of you kind of almost serve like a primary care provider for many people. So it's good to remember this. The treatment options for depression is one and two, medications and psychotherapy. These are the ones that have been most studies, have seen most impact. High up there is exercise. So big body of studies show that exercise 3 times a week for at least 30 minutes with some aerobic components has shown to reduce depression at a fairly good outcome. So treatment of, so medications are recommended still for, still I say, like it's ever gonna be enough. So medications are recommended for 60%, for major depressive disorder, moderate to severe. It doesn't show that it's necessarily worth it in terms of side effects and outcomes in the mild depression, where there's a lot of other things that people can't do. So it's not perfect. 60% of patients with major depressive disorder fail to remit with initial pharmacotherapy. So it's not a really good, response to treatment. Smaller portions remit by each step we take down the road of trying different medications. Treatment-resistant or refractory depression that fails to remit after at least separate and adequate trials for antidepressant from at least 2 different classes. It's usually at that point we've tried at least 4 different medications. Risk factors, longer depressive episodes. They've seen people who have had like longer course of illness seem to respond poor to treatment. Bipolar depression does not respond well to antidepressants. We kind of know, without ever saying we know, if you don't respond at all to antidepressant in the first 2 to 4 weeks, it's probably not going to work. Like if there's no improvement. Other disorders, symptoms, substance abuse, personality disorders, they make it hard to treat as well. And then, I don't know what you've heard about or what you know about genetic testing. We've been doing this for a while. They can test for the genetic variability in our P45 metabolizing system in the liver. So our CYP system, this is not perfect. It kind of makes me feel like, ooh, I can just send my patients to get tested, and then I know if they have like if they're a high metabolizer or a low metabolizer, and then I can custom pick the medications. But right now, the research had not shown that it improves outcome, usually until you're hitting these patients who are just not responding to any medications. So I put this one up for fun. So on the left side, you see the efficacy response. We have a high placebo response in psychiatry with these drugs. So on top, amitriptyline, on tricyclic medications, significantly in favor of active drug compared to placebo, and then you go down. Remeron, Cymbalta, Effexor, Paxil, So all of them are still, despite the low response rate, we're still favoring medications instead of placebo. And the other side of it is the favors medications instead of placebo with regards to side effects and acceptability and like tolerance. And then it changes, and you have like Prozac, escitalopram, citalopram, paroxetine on top there. So we use a lot of like, we recommend to use, and we use a lot of like stepwise, based on research, ways to move from one medication to another. Usually the rule of thumb is you try 2 SSRIs before you move to the next category. This is just an example of 2 of these schematic outlines of how to treat depression in terms of medications. So this is how, like, this is kind of like what we have. The first line treatment is the SSRIs. I'm going to talk a little bit about those because we use a lot of them. They're probably the most prescribed. I mean, my favorite statistics of Iceland is it's one of the happiest countries in the world. It also uses the most SSRIs of all of Europe. So I'm like, they work. So on your left, you see the names of them: fluoxetine, sertraline, citalopram, escitalopram, paroxetine. And then the 3 lower ones are SNRIs. So when we're thinking about, and I'll give you like a little bit of cheat here. So from the top down, pointer and down to the SNRIs, 1 half-life. Fluoxetine down to Paxil, longer half-life down to shorter half-life. Another thing that comes with them from top down is more activating, less activating. So escitalopram and citalopram are more calming than maybe fluoxetine and sertraline. So generalized anxiety on top of depression, that's where I would probably pick a little more calming, right? Paroxetine is an interesting medication. It can be quite sedating, actually. And it also has a very short half-life. So if people forget to take it, they get discontinuation symptoms. So as well as they do with Effexor, the venlafaxine, that they describe like as flu-like symptoms, brain zaps, just very uncomfortable. So these are the kind of things that we look, when we look at these medications, are picking them for our kind of general populations. This is the things like, are you going to take it every day? If not, we're going to give you Prozac. You know, some of them have been more studied in anxiety disorders like panic disorder and PTSD, and fluoxetine and sertraline are still kind of like in charge there. So side effects. Headache, dizziness, upset stomach. This is the most common, like 20 to 30% of people get those. Those are the ones that come in the beginning, they go away. And we kind of remind people like they go away. We often start low and then titrate up slowly so people can tolerate them better. The dose-related ones are the tremors, sexual side effects. Sexual side effects is number one reason why people go off them. And then number 2 is apathy, like people feel flat, which is not, like that's a side effect. Like I keep reminding people, like that's not how it's supposed to feel. People are like, oh, no, I'm not depressed, but I'm flat, great. And I'm like, no, that's not the end outcome we're aiming for here. QT prolongation, so citalopram and escitalopram were found to have an incidence of torsades, and they put a cap on how high the doses can go. These are still really well tolerated medications. So, but we don't use them at as high doses as we used to anymore. And no one in cardiology wants to touch them because of this black box warning that came out they took it back actually, but everyone is just like, like these horrible medications. Increased risk for bleeding during the perioperative period in combination with warfarin. Warfarin and sertraline use the same metabolic pathway, so they can have some problems there. Increased prothrombin ratio. So that's the platelet aggregation. So it's increased risk of bleeding and slower clotting. Can induce SIADH, osteoporosis, and then the SNRIs, the Effexor and the Cymbalta, basically have all the same risk for side effects of serotonin and then more. Yes. Hey. Yes.
When you use it in patients that have depression and anxiety, I've read that it can make the anxiety worse.
Yes.
Do you feel that?
Yeah. So, and that's a really good, because remember I was saying they're a little bit more activating than down the list. So yes, for many people when they start on them, the first symptom, like the first kind of complaint in the first 2 weeks can be excitatory. Like they make them anxious. And this is thought to be one of the reasons why in young people and adolescents, it actually increases, like there's a suicide risk. It's an activation piece. Now, and yes, go for it. Yeah. Yes. And yes, absolutely. And that's one of those side effects that usually goes away. But that in young people, that needs more monitoring. And that's why we go super slow and super low, and we monitor people closely when we're initiating, if they have like a lot of suicidal thoughts. It's still like Prozac is still one of the most used medication in persistent anxiety disorders, because they often need higher serotonergic effects. So we like high doses of fluoxetine is often where we end up going for PTSD, OCD, and panic disorders. So it's a kind of contradiction in like, so I often say that generalized anxiety, that's where I would pick Lexapro or Celexa or citalopram. Does that make sense? Okay. Okay. Bupropion, we don't use a lot on the heart units because it can, it's a good medication. It's one of those medications that I think it started out as an anti-smoking medication. And then they found out it helps with depression. So it reduces the seizure threshold. So that's a bummer. It also increases blood pressure, it's an activating one. So there's no serotonergic effects here, right? So it's norepinephrine and dopamine. So it gives you energy, drive, helps you focus, gets you going, and makes you feel a little happier. Mirtazapine, Remeron, this is our odd one out. We like that one a lot. Our patients don't like it very much because it makes them feel sleepy, groggy, and gain weight. But it's really a good antidepressant. So we now in the hospital use it a lot for the side effects. So we have your anxious, malnutritious, not sleeping patients, give them a little bit of Remeron at night. It does interfere with a lot of receptors, so that it increases a risk of delirium. So we talked a little bit about these earlier, the tricyclics. That's not our first line treatment anymore. And because of the cardiac implications, we avoid them a lot. And then the stimulants. For a lot of people, and we use this in older adults as an adjunct treatment for depression. So when you think about being depressed, you're like, there's the energy, the drive, the motivation is down. It's very hard to get moving and get going. And sometimes we need something that works faster than our Zoloft, that can take up to 4 to 6 weeks for it to start working, for the full effect to come out, right? So we sometimes give people like low dose stimulants as an adjunct, just to kind of jumpstart things and get things moving. And we do that a lot in like cognitive dysfunction. So older adults tolerate these medications okay. It's about being very careful with the doses. So adequate trial, 6 to 12 weeks before we say the response is sufficient. And this is what we talked about, like, if there's no improvement, move to the next step in 4 weeks, right? No improvement. If there's some improvement, keep going, because we do, like, they take 4 to 6 weeks to reach maximum benefit. When to refer. So this is one of the things that the clinic has been working on. If people have mild depression, they have pathways to, you know, like, it's such a beautiful collaboration with the Penn George Institute. And then they have like a good policy of like how to treat depression and refer to therapy. Usually we say multiple failed trials. Multiple means like 2 to 4, or a lot of comorbid psychiatric issues. So if people have, you know, psychotic symptoms, they're suicidal, they have severe anxiety, history of a lot of trauma. This is where we often would say refer to a psychiatrist. And it's hard for us to say refer to a psychiatrist when we know that there's so few of them and it's hard to get people in. I think the wait now in the Twin Cities is 6 to 8 weeks to get in with a psychiatrist. So if you can start the treatment, start the treatment. If you don't think people are safe, then it's the ED. So psychotherapy has kind of similar response rate as antidepressants. The gold treatment is still both together. So these are the psychotherapies that have had a significant amount of research behind them. Cognitive behavioral therapy, acceptance and commitment therapy, and interpersonal psychotherapy are kind of on the high end there of like research behind them. Marital family psychodynamic treatment. There are still people who do psychodynamic treatment with good results. A little bit different than maybe the cognitive behavioral therapy in terms of like how long they last. Dialectical behavioral therapy is used now more and more in conjunction with other things, but also as a standalone program for personality disorders. And then group psychotherapy is often very helpful. The other things that we use, light therapy, ECT, TMS, vagus nerve stimulation. I've never ever used that. I've never ever referred to that either, but the other ones I do know. So I just want to, before we all run off to see our patient, remind us all the important part of this is also to screen for suicidality. And in instruments like the PHQ-9 have it in there, but it's sometimes we have a number on a sheet of paper and we forget to look at what was being said. So depression as a risk factor is estimated to account for 60% of suicides. I would have thought it was higher. Chronic illnesses increase the risk of suicide. So the other risk factors include sex. So men are more likely to complete a suicide. Women are more likely to try. It's mostly, the main difference is mostly in the methods because men are more likely to use firearm than women. Age, so it's like an inward curve. It goes high in the younger population, 18 to 24, gets low again, and then peaks again. So the highest rates of suicide are actually in 75 and older. I think that's still the case. Psychosocial status. So this is, again, the stress of loneliness. So single, so if you think about, you know, you're single, you're older men, lost a spouse, chronic illnesses, impaired functional status, these are the high risk. So just you know, I don't want to end it on a morbid anything, but just please, for all of us, like this is just things to have in mind when we talk about mental health. This is, of course, the most dramatic outcome for our patients. I have talked for an hour. I'm sorry. It's the long pauses and the accent. I'm gonna say, not that I just blabber. Do you guys have any questions? Is there anything else that have come up while we talked? Yes.
I'm just curious about, recently I read an article about physician suicide.
Yes.
A high rate, 200 to 400
Yes.
in the US alone. So is there something being done to address that currently?
So, I love this question because I've always wanted to do a series. This is one of the things that is so important that we keep talking about and that we keep bringing in experts in the field, because it is, I'm not going to go wild and say an epidemic, but it's on the rise. And physician and provider burnout is a discussion. It's like the discussion about it is coming to the forefront. I think there is I want to say there is a task force at Alina that is now working on some strategies to address, like measure, evaluate, and address provider burnout. But this is something that we need to do more. And we need to constantly be talking about with our colleagues and get more familiar with. I don't know nationwide if there's anything being done. There are a lot of little organizations that work with physicians. What's it called? The Bounce Back program. Have you heard that one? It's a burnout prevention awareness. Bounce Back. I went to their conference last year. They were started out of a little hospital that had like significant problems, and one of their team members committed suicide. So they have events every year to bring awareness, to talk about these things and what people can do to both help a colleague and help themselves to get better and address the issue. But again, this is a topic that is if you think about what we talked about today and the chronic stress, for instance, the stress factor and the high level of like intense stress that we often are faced with in our job, we are at risk. We're all at risk. We all need to take care of ourselves and one another. So. Anyone else?